Good afternoon and welcome to the Institute for Government. My name is Nick Davies and I'm a Programme Director here. On behalf of the Institute and Burgess Salmon, who have kindly partnered with us on this event, thank you very much for joining us for this discussion on NHS procurement. The NHS spends over £30 billion a year on procurement. This includes critical clinical services, medicines, equipment, IT, building maintenance, catering and cleaning. Its ability to spend this money well has been under the spotlight during the pandemic, with questions raised about value for money and transparency. In recognition of the need to improve consistency, tackle health inequalities and meet its net zero goal, NHS England has recently created a new central commercial function to coordinate the work of more than 4,000 staff working on procurement across the NHS. So how can the NHS make the most of its collective buying power and ensure that money isn't wasted? What lessons can be learned from NHS procurement during the pandemic? How can the NHS create more resilient supply chains? What role can procurement play in tackling health inequalities and the NHS's commitment to reach net zero by 2045? And how can the NHS take advantage of the changes proposed in the Procurement Bill? To discuss these questions and more, I'm delighted to be joined by a brilliant panel today. We have Jacqui Rock, Chief Commercial Officer at NHS England, David Hare, Chief Executive of the Independent Healthcare Providers Network, Luella Trickett, Director of Value and Access at the Association of British Health Tech Industries, and Patrick Parkin, Partner at Burgess Salmon. Each of our speakers will make brief opening remarks. I'll then ask a few follow-up questions before taking questions from the audience. If you have a question for one of our panellists, please raise your hand if you're here in person or submit them using the Q&A function if you are watching online. And please give your name and organisation when doing so. You can submit questions if you're watching online while we're speaking, and I'll try to get through as many of them as possible. Finally, we will be tweeting from the @IFG events account using the hashtag IFG procurement, and I'd encourage you all to tweet as well. Right, without further ado, I'm going to hand over to Jacqui Rock, Chief Commercial Officer at NHS England.
Thank you very much. Hi everybody, great to be here today. Had a very pleasant walk through the park just outside, so we're all ready and raring to go. So I just want to talk a little bit about sort of some of the NHS kind of priorities and the importance of commercial in this opening speech. So first of all, I'm the Chief Commercial Officer at NHS England. What does that mean? So, I mean, I could do a whole hour just on that, quite frankly, but it basically means that I sort of have the governance of the commercial across the entire system, but also I've got quite significant teams doing buying within national buying, within my function, and obviously I've got oversight and governance of NHS supply chain as well. So, I think it's important to reflect on where the NHS is right now, and you'll all be very aware of that. I mean, we're coming up to our 75th birthday this summer, which we're really excited about. Lots of events. You'll be hearing from the Prime Minister, you'll be hearing from us, and right across everybody that's involved in the NHS. And we've always been an organisation that adapts, that is agile, that brings in innovation. I mean, that's healthcare, right? That's what we do. And so therefore, the commercial aspects of that is so critical to delivering and making sure that we've got those pathways for innovation. We've got the easy ways to do business with us. And we've got a long way to go on that, but it's a really poignant point about, NHS at 75. I mean, the second point I want to make is, and we've already heard, the impact that COVID had. It's interesting because people have sort of stopped talking about COVID. Well, we haven't stopped talking about COVID in the NHS, and us and other health organisations across the entire world. This is going to take us years to recover. This is going to take us years to address our critical things. We've got significant issues with our emergency care, with our ambulances, with our elective backlog, with our maternity and dentistry and primary care. These are all things that you're really aware of, and we've got a long way, and we are delivering some really successful plans on all of this. But again, the commercial and the procurement side of this backs up. I'm part of every single one of those clinical pathways. What we do backs up to deliver. We cannot achieve the NHS's ambitions, our short-term and our medium-term, and recover in the way we need to recover for the country without procurement and commercial. So really important that we make sure that everything is at the right place at the right time, for the right cost, with the right supplier. So we're going on a transformation path as well in the NHS. This isn't just about recovery. This is about bringing the NHS from sort of, where it's been into the future. And we know that tech enablement is going to be absolutely critical to do that. We know there's an awful lot we've got to do to literally, embrace AI, embrace digital, look at our systems architecture. And that applies to commercial, but that applies right the way through the NHS. We are moving to ensure that we integrate health with social care. We need to start bringing in the 21st century genomics, health advancements. It's a really exciting time for the NHS. So that means, from a commercial perspective, all these things that we've got to do, we've got to start leveraging the market. We've got to start, we're one of the biggest buyers. We are the biggest buyer in government of public spend. We've got to start leveraging the market. We've got to start buying really strategically through category strategies. We've got to get a grip on our frameworks. We need to massively enhance our supplier management relationships. There's a whole raft of things which hopefully we'll get the chance to talk to in terms of some of these big initiatives that I've put in place. But I'm really pleased to announce, as we're talking about tech, that today we're launching our new our spend comparison service, which has got a new benchmarking tool right across the NHS. This is just how we're taking technology now and we're actually putting it out there to enable better commercial. This is going to identify, potential cashable savings when you're switching products. It's going to be really transparent. For the first time in the NHS, we've got the data on spend, and that's because we rolled out Atomis over the last year to everybody. Everybody's using it. And now we've got this spend comparison tool again. For the first time ever, everybody's going to be able to see, am I getting the right thing at the right price with the right supplier, and be able to model and forecast options and what do I do if I do things differently. So very, very excited about that. And we've done the forecasting and the modelling, and if the entire NHS system uses a spend comparison tool in the way that we want, it's going to be a minimum of 44 million reoccurring savings. A minimum a year. And this is pretty exciting. And so what is exciting about the NHS is sometimes just switching the dial a little bit has massive impact on our commercial capability. And then finally, just on our people, there's over 4,000 people in procurement in the NHS, over 4,000. There's my team, there's people in NHS supply chain, you've got people obviously in DHSC, and then we've got a considerable amount of those thousands are out in the trusts and in the ICSs. We've got to focus on the capability of those people, on the training, on the career pathways, on the accreditation and the qualification. Because personally, I want the best commercial and procurement service in the world. Our patients deserve it, the British people deserve it, and we can do it. So we've got a lot of we're doing around sort of the people and talent and training. So in summary, hopefully I haven't gone too far over my 5 minutes. There's kind of 5 key things I'm trying to land at the moment, and I've got really, really clear vision, pathways, and execution on. One is, the NHS needs to buy better, right? We really have got quite a bit of work to do on that. We've got to start leveraging and shaping the market. We've got to do this through using sort of category strategies and collaborative, collective procurement amongst us all. We've got to start buying at the right level. We've got to start taking a good hard look. Should we be buying things at a national level, at an ICS level, at a regional level, at a local level? We've got to take a good hard look at that and decide how we do things, because we all know that buying the same product or service 220 times with 220 different trusts isn't good for suppliers and isn't good for the NHS. So we need to do some work on that. Thirdly, we've got to ensure that we put the right pathways for innovation in place. A lot of work's been done. I speak to a lot of innovations, a lot of small SMEs. We need to do better at that in terms of signposting to the market and how people come in. And a lot of that is getting a grip on our frameworks. I could talk a lot about the frameworks, but we need to get a grip on it. Fourth thing is supplier relationships. Historically, the NHS, in terms of our relationships with suppliers, sort of peaks and troughs. We've got to get serious about this now, and we're having brilliant engagement with industry bodies, SMEs, large strategic suppliers. It's going to change on that. And then finally, it's just as I said, it's about professionalising the workforce. So thank you all for coming today. There's a lot. When you look at a panel for an hour, I'd like to talk to you all day, and I'd like to take you down each of these sessions all day. So we'll try and cover as much as we can, but I'm delighted to be here. Thank you.
Thanks, Jacqui, and I'm sure we could have you back at some point in the future as well. We're going to hand over to our next speaker now. It's David Hare, Chief Executive of the Independent Healthcare Providers Network.
Great, thanks, Nick, and thanks for the invitation today. Whether I could speak all day on this topic, I don't know, but let's certainly make the best use of the time we've got available. I think first thing to say is brilliant to put an event on this particular issue. Sometimes eyes can glaze over a bit when people talk about procurement and commercial issues. It's absolutely central to public service productivity and efficiency, and whatever one's views about the sort of future outlook for the UK economy, we know that we are going to be under material pressure to make sure that every penny of taxpayer spend is spent wisely, whether that's on goods or on services, and therefore this conversation is clearly really, really important. From our perspective, who do we represent? We represent organisations that deliver clinical services, both to private patients and to NHS patients. So it's in the area of services that I think we have most the keenest level of interest. And we've followed with interest, and Nick, you mentioned this, the Procurement Bill, currently working its way through Parliament. I think some really interesting principles around that, competition at the heart of the regime, ensuring delivery of value for money, transparency of opportunities, opening up services in the drive towards competition. And certainly for those organisations in our membership that deliver services that are commissioned by local authorities, for example, quite a lot of interest in that. Of course, it doesn't pertain to frontline NHS service clinical service delivery, for which there is effectively a carve-out, and I'll come on in a second to what those regulations might look like. I think it's interesting, and I think it's just worth noting that hasn't been without its contention. So when the bill was passing its way through the Lords, Baron Sprinton, Lib Dem peer, was asking, well, why is it that clinical services for the NHS are excluded from this? Baroness Noakes, Conservative peer, talked about a culture of NHS exceptionalism. Was it right the NHS was excluded from these principles? And the Labour peer, to kind of have a bit of a cross-party hat-trick on this, Phil Hunt was talking about the potential for significant confusion across multiple regimes, whether that be where goods and services come together under different regimes, or potentially you're looking to commission across local authorities and the NHS, because you will have two quite different procurement regimes. So it hasn't been without its contention. That said, the die is cast, and very much I think frontline NHS service delivery will be excluded. So we await with interest as an industry the provider selection regime, which is due at some point over the course of the summer. The last time this was consulted on was early on in 2022, and I think we need to have quite a hard look at the extent to which that will drive the necessary value that we want. Pre-pandemic, I think only around 3% of NHS clinical services contracts were let by competitive tender. The vast majority get rolled over through incumbents, and it's certainly looking at that regime. If you're doing a good job, I think that is literally the terminology, then the ease with which that can get rolled over as an incumbent continues. And I think we are concerned about a degree of watering down of where a provider can go when they've got a concern about a particular decision other than the courts. And I think the proposals in the consultation was that sort of a neighbouring integrated care board would have a look at something and take a view. Well, that to us I think lacks quite a strong degree of rigour. So when that comes out, I think it will be critical. It's not just about the rules, it's also about the culture. I think, when it comes to NHS service delivery, there's been a sort of fairly long-standing now move in rhetorical terms, and I think actually as well, away from competition towards collaboration with integration. I would merely offer the reflection, I think, that pendulum can swing too far. We're aware of the political rhetoric from sort of 10, 12 years ago around the Health and Care Act 2012 and some of the resistance, and I'm by no means arguing for every part of NHS service delivery to go out to market. Much of it, there simply isn't a market. But I think we need, as I come back to that point of principle around why procurement matters, why commercial principles matter, and pay tribute to Jacqui for the work she's done on this in the time she's been in post. It matters in service delivery as well, because that's where the bulk of the spend goes, and it's important therefore that we use procurement wisely, and it isn't an alien term that people just turn away from, that we get that right as we look at services as well as goods.
Great, thank you, David. We're now going to turn to our third speaker, Luella Trickett, Director for Value and Access at the Association of British Health Tech Industries.
Thank you, and thank you for the invitation to be here today. For those of you who are not familiar with ABHI, we're the largest trade association representing medical devices, diagnostics and digital. So that's everything from a tongue depressor right through to a COVID test and an MRI scanner. We've got nearly 400 members. 85% of those are SMEs, and that's actually very reflective of the sector as a whole. And my role, I lead on the work we do around the adoption and spread of innovation, procurement and sustainability. So probably absolutely in the sweet spot of what we're going to be talking about today. And I'm going to kick off by saying the NHS is not one organisation. I often describe it as the biggest franchise in the world. And that does mean that it doesn't do procurement like one organisation would. And as Jacqui's already alluded to, in many cases, that might not be the right thing to do anyway. But even if you're going to do it once, you have to get the whole of the system behaving in the same way in order to get the benefits of doing it once. That all said, the NHS is an incredibly powerful buyer. Jacqui alluded to the fact that it needs to use its buying muscle. I can tell you now, in our health tech space, its buying muscle is absolutely front and centre to every supplier's thinking. Without the NHS, if you don't have the NHS as one of your customers, you're effectively not in business in the UK. It's as simple as that. David and I have chatted about this. While we do sell to his members, his sector, they don't make enough that way to keep going. So that power needs to be used incredibly carefully. I'll reflect on that in terms of resilience. If you buy once and buy big, in the consumer sector, if something falls over, there's enough plurality of supply out there for things to carry on. If that buy once, buy big falls over in the health tech space, a patient at the end of the day suffers. And we saw that through COVID in some of the challenges we had around getting access to things. And I know that the NHS is thinking very carefully about the resilience. Procurement plays its part in delivering on that. It does need, again, as you referred to, really good category management and a deep understanding of the market to get that resilience piece right. Health tech has a really, really big opportunity to play a role in delivering the priorities of the NHS that, again, Jacqui talked a lot about them. Elective recovery, net zero, all of that requires procurement to think differently. If you only ever focus on price when you're undertaking procurement, you won't actually realise the benefits of some of the tech that you're buying. You know, can you use tech to treat patients out of the hospital setting? That'll tick the net zero box, but it'll also tick some of the productivity and efficiency boxes. So we need to see a way of realising non-cash releasing savings that deliver on those priorities, and that is around value-based procurement. Frameworks. Jacqui again talked about that. The NHS's favourite way of buying stuff. That's all well and good, but those frameworks can be too long for health tech. They may not be long enough for other things that the NHS buys, but they can be too long for health tech. You know, if you've got a 4-year framework and you happen to enter the market with a cracking innovation and you weren't on that framework, you're out of the market for 4 years. And that means that tech is not getting to patients. And let's not talk about the frameworks that go a little bit further than the 4 years that they should potentially go for. And so the Procurement Bill, some of the potential changes could address some of those, could bring some challenges at the same time. But the fundamental thing is the NHS will have to use the tools it's given differently because it could carry on just doing frameworks. I've talked about innovation just then as being held out of the market. I just want to say that we believe there's actually 3 types of innovation. There's transformational, clues in the name. There's incremental, where you may get added outcomes, be they clinical or productivity and efficiency. And then you've got what we're calling replicative, which may come to the market at an improved price point. So they're still valuable to you. But the 3 of them need to be treated differently in procurement. And what happens a lot of the time is that incremental and replicative get treated the same way. And we end up with price being the driver and those added outcomes being missed. Now, there are other actors in the system that play a role in making sure that those are genuine outcomes, clinical involvement, patient involvement, and organisations like NICE, really important in that space. But ultimately, as well as having incredibly knowledgeable procurement professionals, you must have that clinical voice, you must have that patient voice, otherwise we won't get what we all want, which is better care.
Thank you very much. And now to our final speaker, Patrick Parkin, partner at Burgess Salmon.
Thanks, Nick, and thanks for having me today. Conscious that some of you won't be aware of Burgess Salmon, we're an independent UK law firm, and our procurement team works across the public sector and advising bidders into large public procurements as well. My work's in the healthcare space, also advising health tech businesses and other tech businesses as well bid into the public sector. As the lawyer on the panel, my particular interest is in the legal developments that David and Luella have already alluded to. And healthcare, as David has said, has the benefit of having not one but two new legal regimes that are coming down the line. First of all, the Procurement Bill. So for medicines, medical devices, all of the consumables that the NHS will purchase will be covered by what will become the Procurement Act, either late this or early next year, to replace the existing legal regime. And there's some real positives in there. We'll have central supplier registers that will speed up the way in which suppliers can register for new procurements. I think in one of your previous sessions, Nick, one of the speakers said that we are potentially going from 71 different methods of registering suppliers down to one, hopefully. And that's very much dependent on the tech being rolled out, but that's a real positive that suppliers into the NHS and the NHS itself can really benefit from. There'll be a central register of framework agreements coming down the line, so you know, building on what Jacqui was saying about getting a grip on frameworks, so that suppliers have an easier way of looking across the market to see what frameworks are available and choosing the one that suits them best and having the full range of suppliers to choose from. So that's another real benefit. We'll have the concept of open framework agreements as well. So yes, it opens the door to potentially 8-year frameworks as opposed to 4-year frameworks, but with the ability to open the door to new suppliers coming online and being a shortlisted supplier during that 8-year term. So it won't be the case as you have now with many frameworks of a 4-year term and no ability for new providers, new services, new prices to get onto that framework agreement. So that, again, is a real positive. And there's a whole new transparency regime with a plethora of new notices. Now, that will come with some complications because the administrative burden on purchasers will be great to make sure that the new notices, from pipeline notices to transparency notices and variation notices to contracts, to make sure that they're updated on an ongoing basis. That will be quite some task. But the quid pro quo is that suppliers will have a real insight into how NHS purchasers are planning procurement, what's coming down the line, and so that they can plan their teams accordingly to put the best bids in. On the flip side, you have the NHS provider selection regime that we've spoken about already as well. And whilst there's a lot of rhetoric in the proposals, and they are just proposals at the moment, we're at the consultation stage, we're yet to see the detail. So we must reserve judgment for now until we see the detail. But at the heart of that are 3 new award procedures, two new and one for competitive procurement. But those 2 award circumstances, the 2 new circumstances that involve, first of all, rollover of existing contracts where the service is good, and the second of which where an authority may want to change the service or change the provider and it considers that a particular provider is suitable, do raise a lot of unanswered questions at the moment. And I think there is potential for there to be some unintended consequences from those new award mechanisms. We've talked about tech enablement. Now, tech enablement is absolutely central, as Jacqui has said, to NHS procurement improving. And if there are rollover mechanisms and an ability for a procurement team to choose a suitable rather than the best provider, query of that is going to incentivise NHS purchasers to really go out to market and engage with that market meaningfully to make sure it has full knowledge of the scope of services that it could procure. That's something that really does need to be looked at closely when the new regulations are published. So, I mean, coming back to the original question, how can NHS improve? I think clarity in those new regulations is going to be absolutely essential, Nick.
Brilliant, thank you. I'm now going to ask a question of each of the panellists before opening up to questions for those here in person and those watching online. Jacqui, I wanted to come to you first. You talked about the long tail of COVID and also the value of transparency. And so I wanted to bring in a question that Chris Smith sent me ahead of the event. And he said that NHS England hasn't yet published copies of 213 COVID-related direct award contracts worth 2.4 billion, nor transparency data for payments over 25k for the last 2 years worth 60 billion. So he wondered what you'll be doing to close the gap and what your plans are for getting better strategic insight from your procurement information to buy smarter and better in the future.
That's an interesting question. I mean, clearly, you know, wasn't aware of that question, so I can't address them things individually. But when it comes to, the sort of the COVID, let's address that first of all, and lessons learned. I mean, you're all aware there's a public inquiry going on at the moment, so there's limited comment that I can make in terms of COVID. But we're very aware of it. We're very aware. Obviously, we're part of the public inquiry, and a lot of these questions and things that maybe the market doesn't feel we've been particularly transparent about, or there's still a lot of questions, will be addressed, and I'm personally part of that response to that inquiry. And of course, I think from a COVID perspective, it's all about the lessons learned, right? It was a really interesting time. If anyone's interested in my bio, I was a Chief Commercial Officer for Test and Trace, and then UK Health Security Agency. Really proud of what we did there. Very, very proud of it. But the speed and the agility that the NHS worked under more of a sort of a command and control was quite phenomenal. And we all said we've got to learn lessons, and we've got to make sure we bring this into our future. My biggest fear is that we just sort of shift that. We go back to the way it was done before. We don't learn the lessons from that. And I think the second part of your question was about I think the question was around sort of transparency and how we signal to the market as such. So again, NHS procurement is not separate from government procurement, right? We are spending taxpayers' money. I work very, very closely with the Cabinet Office. I work very closely with government commercial organisation. I'm still part of that organisation, whether they'll have me or not. I just turn up. It was my own organisation, and so we are as a government very, very, very aware of making sure we put pipelines out there, making sure that we're doing adequate forecasting to the market, making sure again, I want to shift, especially when it comes to innovation and what Luella was talking about. Where are we telling the market what we need? Where are we saying this is our problem? Go help us find a solution. We need to do much more of that. I mean, one of the things I just wanted to highlight, when I came and took this job on, what I didn't need to do was carry out a review of what's wrong with NHS procurement. Did you know, it's one of my favourite facts, since 1950, there's been 34 independent reviews on NHS procurement. 34. So that was easy. I didn't need to go and do that again. And you look back to the Carter review, and the brilliant work that Patrick Carter and the team led there. And actually, I've met him recently. We went through that review again together, which is over a decade ago. And what's been done about it? We identify the things. What's really been done about it? So, we've got to get really, really serious about this. We know what needs to happen, and all the things I talked to and alluded to. We've got to raise the profile of commercial. We've got to raise the profile of procurement in the NHS. I don't need to raise it with our ministers because I think they're used to me coming and talking to them about it, but it just needs to be part of everyone's topic. Every board meeting, every ICS ExCo meeting, commercial and procurement has to be up there. So I've sort of answered a few things in a roundabout way. Sorry if I didn't. Was there any area that I didn't cover?
No, I think that covered most of it. While we're just on the topic of kind of post-COVID, I wanted to actually come to you, Luella, and bring in another question that was sent to me in advance from Professor Albert Sanchez-Grels. So you spoke about resilience, and he asked what panellists think is the right approach to logistics and how much weight should be given to resilience and security of supply.
So, very interesting question, because in some cases, because the focus on price can be dominant, even when the right questions are asked of suppliers about their resilience, it doesn't actually make enough of a difference in some of the ultimate procurement decisions. And I think that is where Jacqui's alluded to the fact that she doesn't want the NHS to not remember the lessons learned. And if you put enough weighting on resilience, you will naturally end up with a more resilient outcome. We know that the NHS is taking a risk-based approach to resilience, and that's a very sensible way to do it, because otherwise you get an industry created in trying to understand the resilience, which is a little bit pointless. But if you can say, do we buy this product from the same country, even though we buy 17 different types of it? You've got to ask another question. If it's not all from the same country and it's from 5, 6, 7 different countries, you've probably got a bit more resilience in that. If you find it's the same country, the same region, you've got to ask even more questions. And that's where procurement needs to play its part. Ultimately, though, we mustn't confuse resilience with business continuity. They are subtly different things. You need both. But what we can't do is go, we buy this from 17 different suppliers, therefore we're resilient.
Thank you. David, I want to come to you next. You spoke about the importance of culture and practice. So I wondered what you make of the current capacity and capability and culture in NHS procurement teams, and what you think is necessary to kind of train them up to take advantages of changes in the Procurement Bill and the provider selection regime when it comes.
Yeah. So I can only really talk about services rather than goods. I suppose I come back to my remarks in my opening commentary. I think that really over the course of the last 10 years, probably even longer than that. And obviously the NHS has been on a journey. You started in the 80s with the internal market and a desire to try to sort of drive greater kind of productivity and stimulate the market through a degree of contestability. I think the last 10 years, that's largely been paused, I would say, because you had a set of legislative reforms that came in 2012, 2013 that almost never really happened, actually, because they were, to quote others, sort of slightly dead on arrival. And then I think a view that, right, we need to try to move to a much more sort of integrated, coordinated approach. And that's when I come back to the statistic about how little clinical service delivery work ever really gets procured. There's contract management, but there's not significant procurement. And of course, then that has an impact on culture, because I think the subliminal message is, well, we don't really do this. This isn't what we are about. This isn't how we therefore drive improvement, whether you're a CCG, ICB now, or a trust. So, I think in looking at, where there will need to be a drive towards procurement, and I think there is some capability out there, but I do worry that culture, which is we in clinical services don't really do procurement, therefore we don't need to worry too much about that, is a barrier to getting that right.
Patrick, changes to culture and practice are very difficult, take a long time. Are there any easy wins for NHS commissioners that are procuring services?
I think that if you take some of the lessons from the Procurement Bill, actually, there are new provisions there that really clarify the obligation now to engage with the market, and if you don't engage with the market ahead of a procurement, to plan the specification, make sure those contract terms are acceptable to the market, you're not including terms that are going to block out key providers from the market. You're warming providers up to the fact that a procurement's coming down the line. These are all benefits that are going to result in a much better procurement. And procurement often gets a bad name because of the bad procurements, not because of the ones that have been planned very well. And yes, they can be resource intensive, they can cost, but that's an investment in a much better long-term service more often than not. So where the Procurement Bill is actually kind of leading the way with clarifying those pre-market engagement obligations, it would be very useful to see some provisions reflecting that same principle in the provider selection regime, so that if a decision is taken to roll over services, or if a decision is taken that a particular provider is suitable, there is at least some accountability and some governance around that decision. It's an informed decision, rather than that decision being taken because a team is particularly resource stretched at the time and doesn't have the capacity to run a new procurement. So I think that would be front and centre for me.
Thank you. I'm now going to open up to questions from the audience. So can I please ask that you keep your questions short and that they are in fact questions and not statements. Please also say your name and where you're from and wait for the roving mic to reach you. So I'm going to take a few at a time. So hands up. Firstly, the lady there, then this gentleman here, and then this gentleman here.
Good afternoon. My name is Jo Newman and I'm from the Cabinet Office in the Complex Transactions team. My question is to all the panel, but to Jacqui particularly. How do you hope to see product development aligned with category management, please?
Fantastic. And then... Yep.
Hi, Edward Jones, NHS Confederation. I wanted to ask a question about the two regimes. We've got a Health and Care Act that's been designed to shift from competition towards collaboration, the provider selection regime doing the same for health service commissioning. The Procurement Bill obviously is cross-government and still based in competition. It's going to cover a range of services, including social care services commissioned by the NHS and local government. So in a nutshell, to what extent does the Procurement Bill help or hinder health and care integration? Thank you.
Thank you. And then over here.
Thank you very much. Some very helpful presentations. My name's Mark Goida. I'm founder of Tomorrow's Company. Over 30 years, I've witnessed so many conversations about what went wrong in corporate governance disasters, where again and again the question comes back to culture. We've been talking about the culture of the commissioner, of the procurer. I'd like to ask a question about the culture of the companies being procured from. Wouldn't it be wonderful if we had a world in which there was a clear way of assessing the culture of organizations we're putting on our registers, having some confidence that their stated purpose and values are lived in practice? I want to ask whether people are aware of something that exists now that does make it more possible to do that, which is a newly established British standard which we call the trust test, BS 95009. I'd love to know if people are aware of it. I'd love to know if it's likely to be in use to help a more professional and rigorous approach to assessing the culture of those we're buying from.
Thank you. Jacqui, I'll come to you first, particularly on that, the first question from Joe on kind of project management and development, and then I'd also be interested in your thoughts on integration and the trust part.
Yeah, sure. So, category management is the answer for me for a lot of our problems. It sort of starts with that collective category management. If we don't collectively across the NHS agree how we're going to buy something in a collaborative way, agree what frameworks we're going to use, what options and choice, how we're going to buy it, who we're going to buy from, all of the things I've talked about they're just not going to land. So it all comes back down. So thank you for the question, to really effective, collaborative, signed up, agreed and intelligent category management. And you asked specifically about if you get the right category management and the right strategies in place, therefore, how is that going to involve product development? So, I've seen and I've run brilliant category strategies and ones that just sort of tick the box. A brilliant category strategy will look at the forecasting. It will look at what our demand is. It will look at where we want to take the NHS in the next 5-10 years, and therefore what products we're going to need, products and services, innovation, tech, consumables, we're going to need. And it should be part of that strategy. And that therefore, so not only do we, as part of that category strategy, all agree, all sign up, this is how we're going to do it. We can message the market and we can therefore ensure that the product development, and again, innovation will be a massive part of that, so will social value, so will net zero. Everything all comes back to that one collective category strategy. So I'm really confident that and we are starting to pick these off now. We're going with, I've got sort of like 5 or 6 ones that I'm really focusing and intervening on and putting category strategies across the NHS. And already we're seeing massive kind of, not only efficiencies, but amazing results in productivity. So it's the answer for me on that one.
Thank you. I'll come to you next, particularly on that question on whether you think the Procurement Bill will help or hinder integration.
Yeah, it's not ideal, is it? That you've got an attempt to try to integrate services. You mentioned social care, Ed. I'd also touch on some of the local authority public health commission services, which will be subject to the Procurement Act when that comes in, as opposed to the provider selection regime. And I mean, the devil will be in the detail when we eventually see the regime, because I think we'll then be able to ascertain just how far they are, or both regimes, how far apart both of those things are. I think it is going to need some quite focused attention on guidance. I think people are going to have to look at how we can kind of support both sets of commissioners, the NHS and the local authorities, to work together. Actually, when you get into if a commissioner is planning on doing a procurement, actually there's sort of a limited range of sort of deviation that you can do on that, because you need to follow a particular process. I think the issues will be more around local authorities feeling they need to test a market and the NHS deciding it doesn't particularly want to do that, because that's the way in which it does things at the moment a little bit. So I think it will be a thorny issue that will need quite a lot of focused attention through guidance.
Thank you. Lola, I'll come to you on the question on product development.
Yeah, so on product development, for health technologies, obviously a lot of the product development does come through collaboration and R&D with the health system itself. So the sort of development process is hardwired into the health system. Where it's more challenging is the framework approach, where the NHS is buying things that already exist. There is an opportunity to have a more strategic relationship with health tech companies around product development. That said, the NHS already has some good initiatives like the SBRI initiative, where they do put out calls for companies to bid for some funding to develop products that meet specific challenges that the NHS has set out. So there's stuff going on already, but I do agree that we could get a little bit more strategic about how we do that.
Patrick, any thoughts that you'd like to share on those questions?
I'll pick up some points on the procurement bill, if I may. I think we've already touched upon some of the positives, and I think I echo what David has said about there's going to be a real emphasis on the guidance and training. And Jacqui, you mentioned, you're a 3,000 strong procurement team, and all of those procurement officers will need not to understand just the procurement bill, but also the provider selection regime. So that will be quite an intensive period of upskilling that's necessary to run good, solid procurements. We've touched upon the improvements earlier on, but there are certainly question marks over, if I dig into some particular aspects, the quality of the information that unsuccessful bidders will get at the end of the procurement. We don't have the language that's currently in the procurement rules at the moment about the precision of the information they'll be given. And I think that's important to give bidders confidence in the procurements that will take place, so they keep on coming back to market, keep on developing the products for the NHS market. There's a lack of certainty around some of the language as to the extent to which the authorities must have regard to the core principles of procurement: transparency, fairness, equal treatment, and what those changes in language actually mean. We don't know whether some of these changes are simply because we've taken an EU directive previously and we're moving it into plain English drafting, or if there is a substantive difference that's actually intended. So, yeah, I think for me it's really a case of an intensive period of upskilling for both those two regimes is going to be key.
Thank you, and I recognise that we haven't actually answered the third question on have people heard of the trust test, so I'll just take a yes or no from panellists on that.
I haven't, but very quickly I think it can be built in to a procurement. I haven't looked at 95009. What we currently have is a mandatory and discretionary grounds for exclusion in the regime. They have been strengthened under the Procurement Bill, which should go some way to making sure that we have credible suppliers with the right culture serving the public sector.
Great. I'm going to ask for yes or no from the other panellists, so we've got more time for questions.
It's not a yes or a no, but ABHI has a code of conduct that all members must sign up to. We also have BSI as a member, and we did a collaborative working session with the Department of Health and Social Care and NHS England.
No, I haven't, but I will look for it. I think it sounds really interesting. Just on culture, I tend to find that commissioners do actually have a good understanding often of what the culture is, but more could be done on track record as part of the procurement process.
We're not going to say
no. I know.
Sorry, absolutely not. But I can. So yes, I have heard of the trust test. How extensively we're using it, I can't answer that. But it's going to be very interesting. I'll look into it. And I think your question was more around the sort of the culture and again, it's another topic, how we're using social value now and how we're using that social value to ensure that you know, as suppliers bid, and obviously it's 10% of their bidding costs now, you know, how, you know, I need suppliers to start helping me with sort of health inequalities, and we'll be looking very much at the way that they, you know, how they recruit, how they treat their staff, their health and well-being. There's a whole range of things on social value. It's probably another topic for another panel, but thank you for the question, because it's absolutely critical. This is about people, and this is about culture, and this is about how we work together.
Thank you. I'm just going to take some questions from online. So 2 related questions, one from Suki Joy and another from Charles Rapson. And Jacqui, I'm going to come to you again first on this. So first from Suki is, what's the best way to get more one-man bands and SMEs into the supply chain without the consultancy premium? And relatedly, Charles Rapson asks, where do you see the role for social enterprise in the supply chain, and what are the barriers for engagement with the NHS?
Okay, so yeah, the one-man band, often the innovators, you know, some of the best innovations have come out of people's garages, right? We all know that. And often the best innovations and ideas have come from clinicians. They come from our own people. They come from our surgeons, from our nurses, from our porters, from our caterers, because they're there on the ground and they see things and they know what they need. So we've got quite a lot of pathways. We've got the acceleration, the AAC pathway, which is set up solely for small, you know, individuals or very small startup companies to come into the NHS, to be able to pitch to us, to get funding, to get grants, and be taken through that whole process. So we have got a lot out there. It's easy to find out about on site, on our website, and obviously I'm happy to give more information. But we do put a lot of focus on making sure that, because that's where the future of the NHS often comes from. And I think it's the same with sort of the social enterprise. We've got particular pathways, which I won't go into a lot of detail right now, but we have got very clear, defined ways to come in, and how you will then be looked after and you'll be navigated through. Can we do better on some of these? Of course, but they do exist, and I'm personally giving my commitment that from a commercial procurement perspective, we'll work to enhance them continuously.
And David, I'd be interested in your thoughts as well on getting kind of smaller providers, social enterprise providers, into the supply chains of your bigger members.
Yeah, I think it's a really good point. I think I mean, we don't tend to in clinical services have quite as many frameworks as Luella and Jacqui have been describing. I think there's probably a bit more local commissioning that goes on. I think that can be helpful actually for smaller organisations, because sometimes the framework model can just be totally overwhelming and huge and expensive and so on. Although I know a lot of work's been done to try to make that better. I think some of the best commissioning that I've seen has really encouraged bigger organisations to partner with, through their supply chain, smaller organisations. And I'd always encourage smaller organisations not just to look at the commissioner and have that conversation, but also to talk to some of the larger and even some of the mid-sized suppliers to become partners to those organisations, and particularly in areas like diagnostics at the moment. And we're hopeful that there'll be some more sort of private sector-led community diagnostic centres coming along. I suspect the provisions for that will need to be quite big organisations, well capitalised, but a focus on their supply chain capability and working with smaller partners, I think, would be good there as well.
And Luella, do you want to add on that?
Yeah, so Jacqui's talked about some of the system support, so the Accelerated Access Collaborative, the MedTech Pathway Mapping, Innovation Service. I have to say, ABHI obviously has a big number of SMEs, and a lot of my job is helping them navigate signposting where they should go to as well. But it's always dangerous when you're sitting next to a lawyer to say something about that. My understanding, and you can call me out for being wrong in front of lots of people, is that one of the provisions in the bill may be that you can look to treating people appropriately, not equally, which could address some of the challenges. So you could make a different decision for an SME as long as it was appropriate and commensurate for what you were doing. Am I right in that?
This is
on-stage legal advice.
Well, there you are. This is where you come back to, I think, to the have regards to language that's in there at the moment, and quite what that means in practice. And this is where we're going to need to be looking at the guidance and secondary legislation. So typical lawyer's answer, I'm afraid, is that we're waiting for the guidance and quite what a lot of the bill actually is going to mean in practice. But I agree that does appear to be an intentional change in language which needs to be focused on.
Great, we're going to take another round of questions in the audience. Can I please ask people to keep them very short? Okay, so we'll take those three. Firstly, the lady over here, and then the first two gentlemen that put their hands up over there.
Thank you. Good afternoon. I'm Anisha Mistry. I'm from the Complex Transactions team in the Cabinet Office. My question is for Jacqui. Thinking about your priorities, Jacqui, as you set them out around buying at the right level, how do we face or how do we tackle the challenge of the buy-in from the regions and different, given the federated nature of NHS? It's not just about setting up the right sort of procurement strategy and approaches, but it's also about getting the buy-in from the people who are the budget holders. And how do you expect to address that?
Thank you. And then, firstly, back row over there, and then, 2 rows in front.
Gavin Hayman, Open Contracting Partnerships. So we work globally to open up and transform public procurement. So it's a question to all 4 of you. Patrick, you said about the new UK Procurement Bill has the noticing regime. It's different. It's going to require people to adapt. At the same time, those notices will be born digital, so we'll actually have a data set on what the UK is buying, from whom, for how much, in a comprehensive way, so a single source of truth. My question to you all is, overall, do you see that as a burden or a benefit for you in your particular roles? Thanks.
Thank you. And then 2 rows in front.
Thank you. James Sibley from the Management Consultancies Association. I actually attended another Institute for Government event on procurement and use of AI. And I wondered, that covered things like designing tenders, assessing tender bids. Is this something the NHS is thinking about, the challenges and opportunities of AI in procurement? Thank you.
Thank you, James. Always keen for people to say how good our other events were. So thank you for that. I'll give you your £10 afterwards. So I might come to Jacqui first on those 3 really interesting questions about getting buy-in, whether transparency is a burden or a benefit, and AI.
Yeah. So getting buy-in. I haven't really been described as a wallflower, so I'm pretty loud in terms of just raising the profile of commercial and getting people to sit up across the NHS and listen to it, and that, and my brilliant team as well. Obviously, it's not just about me; it's about the team. And so we've been going out and we've been very, very. You have to be quite deliberate. Right, but the real answer to that, how am I getting buy-in from all of the chief execs, all of the boards, the clinicians? I show them the data, right, and that's what's been missing. I don't think we've been doing a very good job of that up until now. When I can sit down with a head of an ICS and I show them what they're buying, where they're buying, in layman's terms, how much they're paying for it, what service they're getting, and then I show them what they're getting in another trust. Or, all of a sudden everybody's ears prick up. When I can show them the efficiencies, when I can show them how we can absolutely, fundamentally, through what we're buying and how we implement it, impact because it's all about the patients at the end of the day. People really listen. When I bring clinicians into a room, had a brilliant example a little while back where we brought a lot of the top cardio surgeons in the country, and we had a discussion about stents and how many different types of stents we were buying. I'm not going to go into the numbers here, but it was significant. And actually, just that one conversation, we managed to basically halve the amount of stents that we need to buy, and therefore we get a whole new strategy around it. So it's about engagement. It's about talking to people in a language that they understand, whether they're running a trust, whether they're running a clinical pathway. It's showing them the data, and it's taking people on that journey of how commercial is not only fundamental to what we're delivering in the NHS, but how it can help them. So that's been really, really successful.
And then can I ask another question of AI, because it's actually something I wanted to ask as well, because one of the kind of advantage or disadvantage, depending on your perspective, for generative AI is it makes it much easier to bid, and therefore the volume of bids you might be receiving might be much, much higher. So I just wondered kind of what work you and NHS as a whole have done to prepare for that.
And the answer is yes, a massive yes. And we're still in the middle of sort of prepping for that. In fact, our Secretary of State has just been on a trip to Japan, and sort of AI has been very much at the forefront. And so, of course, I'm getting questions like, so how do we buy this, Jacqui, and how do we buy this effectively? I've been blessed because recently you'll be aware that NHS Digital has come into NHS England. So I've now got a team, a large digital buying team, that work, and they are absolutely fantastic. And its capability that was sort of outside NHS England before. So I am working, I'm not going to go into too much details at the moment because we're still working through that strategy, but I've got great tech buyers. We're looking at it quite fast because, we need to go out and start procuring AI, and it needs to be bought differently. We need to understand how to buy it.
And then finally, just on that transparency question of like benefit or burden.
Well, transparency can never be a burden. You know, everything that we do in the NHS, this is our service, right? And I welcome it. There's the quick answer.
Thank you. David?
Can I pick up on the AI question first? I think it's a really interesting question, and the extent to which procurement drives innovation in AI, or providers generate the innovation, and then that kind of flips through into what commissioners do. I think there's some really interesting areas within this. So, one of the things we're seeing a lot of providers using AI for at the moment is bringing together patient feedback. Some really interesting platforms for being able to take the legion of bits of patient feedback that you get, particularly as a national provider, and be able to very quickly identify themes that allow you rapidly with your clinical teams to look to put in place different changes. That, I don't think, is a particular procurement question, although that might start to flow through into how things get commissioned, but it's very much being driven by the provider. But I think there's also some really interesting questions around kind of provider innovation driving commissioner nervousness. So a really interesting area on that is scanning and the potential for AI to massively improve the quality of scanning. But of course, that isn't without its contention because of the consequences on the human labour force. And so sometimes, we've seen examples where bids have gone in around, well, actually, we can quite radically change the workforce. And the commissioner has got rather nervous about that because that requires a quite challenging conversation with the human capital that you've got within that system. So I think it's absolutely fascinating, moving at speed. I say the extent to which procurement's driving that, or it is providers sort of driving that change, but procurers will need to respond to the way in which that's working.
Thank you. Well,
I'm agreeing with Jacqui in that transparency should never be seen as a burden. What is a burden sometimes is the number of times you have to provide the same information to different people, and centralising all of that so that suppliers only have to do it once would be a great benefit.
Thank you. Patrick, final word.
Chime with what the others have said. I think is very important that it's not a burden, and I think that when we see the new notices published, the success of that regime is going to depend on how straightforward it is for those to be completed, so that the quality of information in all of those notices actually serves the intended purpose. So absolutely benefit rather than burden.
I'm actually going to do one more final question to Jacqui, just pick up one from online. So Paul Featherstone has asked, how can commercial colleagues in NHS England work better with colleagues in DHSC and continue to reform the relationship to improve commercial outcomes across health?
Well, you've got a great question. I think we work brilliantly together, actually, already. We're one health family. And I think this is really important. As Luella mentioned earlier, the NHS isn't one organisation. That's very true, but we are one family. We are one health family. And so whether it's the Department of Health and Social Care, NHS England, out in the Trust, one of our numerous, and we've got many, many arm's length body agencies, we are all still one health family. And I spend a lot of time trying to bring that family together, in effect, and how we work together and how we support together. So, I'm very, very close, and my team are very close to the team in the department. I've mentioned before, we're very close and getting even closer to the government commercial teams, because at the end of the day, we've got to focus on NHS, but we're all spending taxpayers' money. And the Procurement Bill is a wonderful thing that brings us all together as well, because it's across whether you work for Defence, or DWP or HMRC. This is for all of us. So actually, I think just the commercial unity of the government is really, really important, and I'll continue to ensure that we promote that.
Thank you. And on that note, I'm going to bring this event to a close. Thank you to our 4 panellists for a brilliant discussion, to Burgess Salmon for supporting the event, and thank you to all those who've watched today or listened back later. Our next event will be Data Bites number 42, Getting Things Done with Data in Government, which is tonight at 6 p.m. Do tune in, and until then, thank you and goodbye. Thank you.